second theme of this session is about smart operate. So how you make your hospital smart in operations, operational. And with that, I would like to invite Dr. DILEEP Raman, who is co-founder and chief of healthcare in Cloudphysician. And he is an internal medicine, pulmonary critical care and sleep expert, American Board of Internal Medicine certified. And he is going to talk about how to become smarter in care delivery, as well as he would touch upon empowering the people organization in terms of becoming more smart in managing the whole operation in a hospital or a healthcare system, not necessarily a physical building of a hospital, but how it can be other way around as well. So I would like to invite DILEEP for the deliberation. Over to you, DILEEP. Thank you.
Thank you. Good afternoon, everyone. The topic that we're going to talk about here is a little bit around what has been talked about previously, but also a lot since the pandemic, because it has required practice change among physicians. But there has to be a connect to reality. There has to be a connect from, just like you have in clinical medicine, from bench to bedside, you need it from the engineering room to the bedside. So I hope to accomplish some of that in this talk. And the key issue that we face today is that healthcare is obviously slow to accept technology. We all know that it is a fact, not just for providers, but also for patients, because they encounter problems like, why can't I get my lab on WhatsApp? Why can't I get my data to me when I need it, when I'm concerned about it? And it's just been a industry-wide problem. And some of the reasons have been legacy things that you see in the industry, complex IT jargon that maybe clinicians are not familiar with, digital health roadblocks that have existed, say, in North America that were cut, copy, pasted to India and are perhaps not relevant for our country. So just like we skipped from pages, we completely skipped the pager generation, we went straight to mobile phones, perhaps something like that is possible in healthcare. And that is what we are seeing. And if you look at the differences between developed and developing nations, it's pretty clear. The scenario, even the US is dealing with clinical expertise shortages. They also have burden that is very difficult to manage given their current constructs. Their doctors and nurses are perhaps aging and actually retiring, creating a vast gap in their service provision network. But in the developing world, outside of North America, the problems are of a different kind. The population mismatch is obviously huge. The product itself, so for example, like I was giving you the example of technology, there are too many legacy frameworks that are slowing down, for example, the Indian ecosystem to catch up to the West. In some ways, we are exceeding, but we may have to discover our own way, because if you use the template of the West, perhaps it's too cost effective and just not designed for India. And if it's not designed for India, it's not designed for Southeast Asia, not designed for Africa, basically the rest of the world. So there are a lot of barriers which I've just talked about, and they need to be dealt with. This picture is a panoramic view of the Sloan Kettering ICU, and this is from a paper in 2014 when I was a fellow. It talked about a smart ICU. This was by Halpern, who's a very respected figure in this space, and they talk about various connected systems that exist in an ICU. It could be RFID tagging, all the monitors that you see around you, some frameworks to connect patients' vital signs, so on and so forth. Fairly complex, very highly cost impactful, say anywhere between $7 to $10 million to set up a full smart ICU bed in the US. Not cheap. But these are legacy steps. There is no rule book that says we need to follow the same framework. And this was just in 2014. So if you think that anatomy takes thousands of years to change, physiology perhaps takes a few hundred if you are looking and discovering new mechanisms, technology can change in months. So what I would like to share with you is that when you are in a space of frugal innovation and you're forced to figure out solutions, you have a way to do it, and you look at ways to reinventing how this can be done. Not so much reinventing the wheel, but actually fixing the way you drive. And unnecessary functions and expensive products are not the way to do this. So what we try to look at is, how do we reduce this complexity? So just like you have the legacy systems, you can go towards Bluetooth, you can go towards a software-defined WAN. You do not need an MPLS network that is expensive. So for instance, you can use QR codes in the place of standard barcode auto ID systems that exist in the West. And we can go mobile first. So US-based EMRs are not designed mobile first. They are designed workstation first. And to us here in our ecosystem, that's perhaps a fundamental flaw. Every person we have here is empowered with the mobile phone. And I think designers, product engineers, and people who build software for healthcare need to take this path. Because if you do that, you will come to newer tools such as robotic process automation, computer vision, some of which we in our team use today to leapfrog these challenges. This is what we do now. So a smart ICU in 2014 in the US today looks very different from the one that we execute in India. It's an ICU in a box. You ship this to any remote place or a metro city, it doesn't matter. Tell the IT team how to set it up. If they don't have an IT team, no skill required. We've color coded the wires so that they put it into the right box and you're online in a couple of weeks. But you need to break it down, just like I was sharing those steps with you, RFID tags, QR codes based methodologies, SD-WAN, Bluetooth, all these things can be used to leapfrog what was thought difficult to do or expensive to do so far. Once you layer the framework for the hardware, you have to work on the software segment before you can call yourself smart. And this is a work in progress across the board. We have reviewed about 35 different Indian HIS and EMR systems, and essentially they are banking software that have been repurposed for healthcare. That's not how healthcare EMRs will get fixed. It requires doctors and nurses working shoulder to shoulder with product engineers and software designers to actually build something that they will use. So if all of this life-saving data has to come in one place for the clinical team to create an impact, which is where actually all of us get paid, because you can buy software, but if it doesn't translate to ROI, better patient care, better outcomes, we're just poorer with a fancy car. So an example that we use in our system is that we had a challenge where a lot of these bedside monitors were either made in China or had a product manual that was written in Mandarin Chinese. So integration by standard HL7 methodologies was just not possible. So what we did was we deployed a computer vision tool where our camera system actually takes the data from the monitor visually and ports it to the platform, saving time for the nurses by means of automated charting using computer vision. Another patent that we got granted recently is the one that looks at patient outcomes and severity tracking. So now you'll say that, you know, we have systems that can check news score or an Apache score or SAPS. Well, the challenge is that these scores have not been tested in the Indian population. There is absolutely no validation data for the Apache 2 or for that matter Apache 4 in India. And the problem is that even NABH guidelines suggest those scores. They don't actually mandate that you have to use them, but they give it as examples. And hospital thinks that, you know, that's the Bible, we have to use Apache 2. And the problem is that if you rely on Apache 2 to benchmark your ICU, I can guarantee you don't know what you're doing, because it has not been tested for an Indian population. It has not been calibrated for an Indian population. So, you know, in our practice, we need to move from pattern recognition to pattern creation. And that is where data can help you. We have about 60,000 patient data sets now in our ICU network. And we've created a long short time model which uses machine learning principles that is summarized on this slide, where we use all the usual parameters that you would associate with an Apache model, but we've broken it down into 3 to 6 hour time-stamped segments. And each time-stamp segment is compared with the next one, giving you a real-time tracker on how it's doing. The easiest example would be, if you guys are cricket fans, you would have seen the current run rate and the expected run rate graph, where you're supposed to, you know, catch up with Pakistan or Australia. This is something similar to that. If there is a deflection from the patient's story comparing the previous 6 hours window, that's when the clinician gets an alert. So think about this. If you have a sepsis patient and the patient is having a heart rate of 130 for 7 hours, the clinician is unlikely to do anything about it. That's what happens. The alarms keep going, nobody pays attention. These are not actionable insights. What we have to do is change them from actionable to something that can be done. So if the doctor knows that the heart rate was 130 and now it's 160, there's something that needs to be done, or in the opposite direction. That's the point of this patent. Another one is actually a machine learning speech tool, which we developed, that if this streams correctly, you'll be able to see it, is that our goal was to cut short the note writing time of a doctor by 30%. So if all the data is on the platform, the one-click button simply pulls up a registrar level document on the platform, and then the clinician just needs to read through it and once they are okay with what the registrar level note that is auto-generated tells them, they can just put in edits. So that, like I said, cuts short our own doctor note writing time, increasing clinical efficiency. So the reason why I'm telling you these things is it's related to the message of what we want as an empowered provider and empowered patient. And if you look at, again, visionary writers, this is the same author, Halpern, and from 2014 to 2017, you can already see a change in his thinking. And this is something about the ICU of 2050 that he talks about in this paper in intensive care, which is that it's all going to be centralized. Centralizing data is not the problem, but centralizing care and linking it with an impactful outcome is the challenge. If it is a challenge in the US, it is about a 10 to 15 times bigger challenge in countries like India, which means the rest of the world essentially. But remote care is here to stay, because it's not like you say, I'm going shopping and it's e-shopping on Amazon. It's understood that you're using some form of technology. So tomorrow when you say that I am providing healthcare, you don't have to say that I'm doing health tech. It's assumed that you're using the best tool available to make yourself the best doctor or nurse possible. When we look at electronic health records, in fact, we're trying to move away from that term because it's a legacy term. We don't think the term EHR or EMR has any credible value today. What we think is it's going to be a merger of collaboration, multiple doctors, multiple nurses, and the family member working together. All the data is there, that's the EHR piece. But your patient status is rich and live. The patients know that, the providers know that, everybody's on the same boat. And you get adaptive and agile research right from the platform. So imagine if the platform is linked to a database of all the journals or guidelines that were published for the top 60 diseases that you can see in an ICU. This is not a care plan or a pathway that I'm talking about. I'm talking about analyzed, nuanced decisions per patient at the disease profile level. It's very different from just a template. All of that's going to come together, and you're going to move from just AI to AI. Because everybody thinks that AI is going to replace the doctor. It's not going to happen anytime soon. And in fact, 98% of all COVID-related artificial intelligence tools are unused today. They're either non-monetized, non-sellable, or non-used. What you need is what's going to help the doctor or the patient or the nurse. That's it, which is a combination of these, but you put the human in the loop, put the human in between when you're doing these things, and then you get at something that's actually useful. So, let's step back a little bit. This was all data, this was all paradigms, and some of it is in process. We are doing some of these things. However, if you walk into any medical records of a legacy institution, I trained at a medical college, you will see dusty racks of medical records, row after row. That's how my memory is trained. But it's error prone, it's clunky, and it's certainly disconnected from what needs to happen. And if we continue down this path, it's just unviable. You look at US on one side, they have priced themselves out of a viable market. You look at the UK, they're in a similar problem. We cannot go down that path. And if you analyze the problem statements, you will look at two key actors when you're on this stage of healthcare. One is obviously the patients, the recipients of care. They are disenfranchised, they don't have a say in their care. And then there are providers, possibly burnt out, less data, in a rush, seeing 45 to 50 patients a day. That's not an ideal healthcare system. That is certainly not an empowered healthcare system. You look at the numbers, 54% of patients that are seen in the ICU do not comprehend the status of their loved ones. It's incredible. And so you would think the other 46% comprehend it. But those 54% that don't understand, only half of them are even interested in asking, doctor, I need your help. Can you help me understand? This is the definition of someone who is not empowered, someone who is disenfranchised. And if you look at the providers, at the time of COVID, this number is higher. This data is from 2017, from AMA, the American Medical Association. Incredibly high risk of burnout. And the tragedy is that all this data I showed you is not Indian data. If you look at Indian data, it's probably worse. Someone needs to test it. I looked at a couple of reports. They say that the numbers are like 70 to 80% of patients do not understand what's happening in the ICU. So what do you do about it? Well, at least in the realm of burnout, this is again from the AMA paper, cut down monotonous documentation, prioritize workflow fixes. I just picked two. There are 7 recommendations. You can read them. But the key point here is that if you want to fix healthcare, you either empower the provider or you try and empower the patient. The route that we are choosing is to go to the provider first, because we think we will get to the patient eventually. just get the person who's got the patient's interest, top of their priority, which is the doctor and the nurse. So putting all of what we had together, if you were to look at what technology is supposed to do, what your smart hospital is supposed to do, your guiding light, your North Star should be to figuring out how can you make more time for doctors and nurses so that they can focus on things that technology cannot replace, which is interpersonal aspects, communication skills, getting the entire family or the patient on the same page as far as their treatment plan is concerned. So that interpersonal aspect, tech today can't fix it. I was watching this movie, it's called I Am Mother. It's on Netflix. You should try watching it. It's a robot that has brought up a child solo. And it was interesting to me because I was trying to read about what the interpersonal aspect of healthcare really means. And it's a difficult challenge. It's a very thought-provoking movie. So I'd like to conclude by saying that if you look at these two actors, use any tool you have. I've given you some examples, and move towards that smart ICU delivery model or smart care delivery model, which is definitely possible. It is not a pipe dream, it's happening today. You are going to end up with empowered care. That is the only way you will end up with empowered care. So thanks all of you for a hearing. Happy to take questions.